So I did a lot of my trauma training in Detroit, where we saw a lot of hip fractures. That's kind of the first group of people that'll come in and see us. So hip fractures, they tend to be older patients, somewhere in the 60s, 70s, and they have a fall that is detrimental. Obviously, they won't be able to walk afterward, and when they come into the ER, we'll find that they have a hip fracture of some sort. There are a couple ways to fix them, and we're trained obviously in both. So the trauma portion of it would be plates and screws. The other portion would be hip reconstruction, which is what I specialized in. So if somebody has an acute fracture of their femoral neck, they'll come in and I'll end up being able to do a total hip or a hemiarthroplasty on them, replacing that part of the bone that's broken. Hip fractures don't heal the same way that other parts of the body do, so we have to treat it in the way that it's meant to be treated. Beyond that, people can be young and healthy, hard laborers. They come in with terrible groin pain, and they can't function. They can't do the job that they were wanting to do. It's part of their living. We're trying to get them back to doing what they want to do. Our goal is not to put a bunch of restrictions on you and fix you. Our goal is to get you back to doing the things that you love. For those people, it's part of their livelihood. It's their family. It's taking care of their home and their family. So it's important for us to be able to do those things for them. So people will come in with terrible hip pain. They'll come in with inability to squat or do some of the motions they used to do. A lot of people come in and say, I can't tie my shoes anymore. And that's kind of the things that we can fix for them. We can improve their range of motion. We can improve their daily pain. For those patients, they almost universally get a total hip replacement, where we replace both the acetabular side, which is the cup of a ball in a cup, and then we replace the ball side as well. You're up and walking the same day. It's a very, very quick recovery for hips, which is something that I love. Patients also love. They get immediate relief when they wake up. That pain in their groin is gone completely. They have incisional pain for about 3 weeks, but all that passes, and all they're left with is a nice functional joint. So that's wonderful. The last patient population that I see is somebody that has previously had a hip replacement, and they're no longer functioning the way they want. There's loosening of the stem. There's pain in their thigh when they get up and walk. That's called startup pain or mechanical pain. Those are the things that we look for on an x-ray. If there's loosening or loosened Cs around their instrumentation previously, this is something that needs to be revised. Oftentimes there's a big bony defect where they have lost bone over time, or they have something called osteolysis, where the bone is slowly resorbing around their implants. At that point, this is where my training from Cleveland Clinic comes into play. So at Cleveland Clinic, we learn to do pelvic reconstructions, large pelvic reconstructions, where we're using augments and we're rebuilding the pelvis so that they can actually have a cup put back in. A lot of the times they're missing so much bone that half of the pelvis is pretty much gone. So our job is to reconstruct the pelvis first of all. Second of all, get a nice stable femur in, and then being able to get them up and moving again. That's quite satisfying. It's incredibly difficult, but it's quite satisfying.